Yeah, I'll get I didn't realise we started.
Yeah.
Right, Becky, we've got a red call coming in.
Okay.
Elderly chap, been found on the floor. EMAS have called him through. Heart rate's about 110.
Okay.
Blood pressure's 109/67. Temperature's 35.3. Got a couple of minutes to prepare. He's a little bit confused.
Okay, any other information?
Smells strongly of urine.
Right, okay, so sounds like might be sepsis then.
Yeah.
Let's get ready for that.
Alright everyone, this is Dave.
Hi.
Hiya.
Hi, Dave.
This is Dave. We found Dave on the floor this morning.
Okay.
His carer called 999
Right.
when she came in to get him up and found him on the floor in
Yeah.
the hall. Don't know when he was last well, but she put him to bed last night. I think he might have dementia. He's been very
Right.
confused en
Okay.
route. Big bag of medications at home. We've not been able to do much with him. Pulled his IV line out.
Right.
Obs are stable.
Yeah.
Blood pressure's 105, 110 systolic.
Okay.
Heart rate's about 90 to 100.
Okay.
All right. Dave, you're in the hospital now.
Pardon?
I'm going to
What?
leave you here with the doctors, okay? All right.
Yeah, don't worry,
Okay.
Dave. We're going to look after you.
He's got a daughter, but I don't
Yeah.
think she
Who are
knows
you?
that he's in yet.
Who are you?
I'm
Who are you?
Becky, I'm one of the doctors. We're just going to get some bits and
Get a
bobs
bit of
on.
oxygen, Dave.
Jamie, you okay with the oxygen?
Yeah, it's
and
fine, we'll
get,
carry on
get
there.
the monitoring on.
Sure, Becky.
Right, Dave, can you tell me what's happened today?
Oh no, don't know.
You don't know. Okay, do you know where we are?
No.
No.
Hang on, you
And
take
any
it.
pain
Where are we?
anywhere?
Who are you?
I'm Becky, I'm one of the doctors. You're in A&E at the Royal Infirmary.
Why? Why?
Well, I think your carers found you'd had a bit of a fall and they wondered if you might have a bit of a waterworks infection.
Oh,
I'm just going to have a little bit of a look at you. Let's have a look at our numbers. Okay. Right. Just going to have a little listen into your chest, Dave.
oh.
Do you want me to get a candle and some blood?
Oh yeah, thanks, Jamie. That was brilliant. Okay, a bit quiet at the left base. Could you get a temperature for me as well?
Yes.
Just going to have a little
35.
feel of your tummy, Dave. Oh, that a bit sore down there.
A little scratch in your hand.
Oh, what are you doing? What are you
Just a
doing?
blood test.
Right, so he's got a bit of reduced air entry at the left base and he seems quite tender suprapubically. I know his temperature's a bit low, so I think we're probably hitting on the SIRS criteria here. So I think this is probably sepsis, which explains the confusion. So you're right to do all the sepsis bloods. I'll get one of the pro formas. And Dave, do you know if you're allergic to any medications at all?
Don't know.
You don't know. Okay, well I'll just have a quick check on the system, but presuming not, I'll prescribe some coamoxiclav because that'll be the
1.2.
chest and urine, won't it? Yeah, that's great. I'll request a chest X-ray and we'll give some fluids, kind of as per the sepsis. You happy with that plan?
Yeah,
Think there's
that's
anything
fine.
else we need to do?
No, that sounds good.
No. Okay. Right. I'm just going to get the paperwork and get all that prescribed and the X-ray requested. Okay.
Right then, Dave, just a little bit of antibiotic for you.
What for? What for?
Just to make you feel better.
No, they want it.
Yeah, just to
No.
make you feel better.
Ooh.
Just the antibiotic going in now. That's done. You right there, Dave?
Where am I?
You're just in hospital.
With my daughter here.
She's on her way. That's the antibiotic in. A little bit of fluid.
Just going to double check. So you don't think you're allergic to anything, do you?
Don't know. I can't stay here.
Oh,
Just
stand
gonna
back,
get
boys.
that
Stay.
prescription
Stay.
finished.
Oh, go get some help. We're just trying to get off the
Yeah,
bed.
just a second. I'm
Oh.
nearly finished my prescription.
Okay, I think we're good. We're not going to fall. We're all right.
Is it raining?
Yeah.
Do you want a hand, Jamie?
That's all right. He nearly fell off, but we caught him.
Oh, well done.
So, good morning and welcome to the Leicester Gem Conference. I hope that you would have spotted that this was a simulation. Some things went well, some things didn't go quite so well. And what we want you to do is just quickly feed back to us about the things that could have gone slightly better. What did you spot in that scenario that didn't go the way it should have done? This is the interactive bit. This will happen throughout the day, okay? So get used to it, because we're not here to preach, we're here to engage. Yeah, please.
Hand over from the ambulance to start off with. They could have got more information. Where were they found? What were they wearing? Was it up on the stairs? Whereabouts?
Thank you, yeah. So there was a lot of missing information that might have been relevant during the ambulance handover. Yeah?
Communication with the patient.
Communication with the patient, yeah. There wasn't very much, was there? What did you spot about the interaction in particular?
Well, rather than kind of having 30 seconds just to explain things clearly about where they were and what they were doing,
Yes.
it just kept, they were very reactive just to stuff that he was doing.
Yeah.
So they didn't kind of set him at ease in any way. They just kept.
So there was a little bit of reassurance, wasn't there? But probably not enough to help keep him settled, which resulted in him almost falling off the couch, which obviously we couldn't replicate. Although there's quite a few more trauma physicians in the room, so we might have been able to get away with a broken hip. But apparently the insurance was too expensive. Okay, what about other aspects of the actual resuscitation scenario? Did you spot any deliberate faults?
Not checked about his allergies.
Yeah, so the antibiotics were given before they checked about his allergies, and of course if he's got confusion, which appeared to be the case, then the reliability of his information is slightly in doubt. Okay. How are we doing? Okay. So we're going to run the same scenario slightly differently, and this time hopefully you'll see there are some improvements. Yeah. Okay. Do you want to speak?
Morning, guys. Just EMAS are on their way with an elderly gentleman been found at the bottom of the stairs, a little bit confused and agitated.
Okay.
Numbers wise, he's got a GCS of 14, he's losing 1 for confusion. His heart rate's 110, respiratory rate 14, blood pressure 109 over 67,
Yeah.
SATs 95 on air, he's got a normal BM and his temperature's 35.3. They're en route, going to be a couple of minutes.
Okay, was there any other information at all?
So as he's found at the bottom of the stairs, a bit agitated, a bit confused.
Okay, anything else?
They said he smelled strongly of urine.
Okay. So,
Okay.
an older person who's fallen, obviously have to bear in mind at the bottom of the stairs, but it could just be that they've fallen in the hall. And thinking with the low temperature and high heart rate could always be sepsis, because obviously that's very important. We don't want to miss that. We're concentrating heavily on that at the moment, so I'm always thinking of that at the back of my mind.
Yeah, could be.
Obviously might have hurt himself as well.
Okay. Yeah, I mean, fair enough. However, we also need to think what he effectively have is an older person
Yeah.
with trauma who's hypotensive, tachycardic, and hypothermic. So
Okay.
it could be just, hypovolemic shock secondary to bleeding from some
Okay.
source. So that would be something to think about as well, isn't it?
Yeah.
Because it all fit the criteria.
Yeah.
Because in somebody that in that age group, falling down a full flight of stairs is like you and me being hit by a Land Rover at 50 miles an hour.
Okay.
So we need to think of that. So the three things you need to probably look for is, why have they fallen?
Yeah.
What injuries have they suffered as a result of the fall, and how can we stop them from falling again? Because he's
Okay.
fallen once, he's high risk of falling again, and we
Yeah.
don't want him to break a hip if he already hasn't done it.
Oh, okay.
Yeah.
Right. So,
So-
a bit more of an ATLS approach maybe
Yes.
for this patient
So
there.
why don't you take the patient, and
Yeah.
I will take the handover
Okay.
from the paramedic.
Yeah.
Yeah.
Sure, no problem.
All right, everyone. This is Dave.
Hi, Sarah.
Found Dave on the floor this morning with carer phone 999 when she came in to get him
Dave?
out of bed.
Dave.
Sarah,
Yeah.
is it all right
My
if you
name's
tell me the
Becky,
full
I'm one of the
story,
doctors.
and I get
Oh.
Becky to get
I'm
on
Becky,
midday
I'm
because
one
he
of the
looks
doctors.
quite,
We're in the emergency
unsettled. I just
department
want to
of
have
the
a chat. Tell me
hospital.
what's going on.
Because you've had a fall at
Found Dave
home, we're
on
just a
the
bit
bottom
worried
of the
about
stairs this
you.
morning on the floor in the
Okay.
hall.
And I'm just going to have a bit of a look at you, if
Daughter's,
that's okay.
He's got a daughter at
Can
home.
you
She's
tell
not
me
sure
what
he's here.
happened?
Where are we?
Remember what
Where-
happened?
where are we?
Agitated, heparin
Where are we?
We're in the
not
emergency
having
Who are
much
you?
any
Who are
IV
you?
access.
My name's Becky, I'm one of the
Observations are
doctors
stable,
here,
blood pressure's
and we're in the
105
emergency
to
department.
110 systolic.
Okay.
Heart
You've
rate
had a
between
fall,
90
and we just want to have a
100.
look at you and
I
check
think he
you
might have
over.
dementia. He's been quite confused.
Okay.
He had a large number
I'm
of
just gonna
medications in
I'm
the
just
house,
gonna
so
start
we
by
administering them in.
having a little
Okay,
look
so
at your
he
neck, if
lives
that's
alone.
okay.
Yes.
He's got
Okay, would you
carers.
like some
Yes,
monitoring?
at least once a day.
There's a
Please,
daughter
can you
there,
get
so and he may have some
Saxophone,
pre-existing
respiratory
confusion.
as well.
I think so.
He's
yeah.
on
Heart
multiple
rate,
medications,
pressure,
and he's had a fall,
temperature.
Yes.
and he's been
That'd
tachycardic,
be great. And once you've
tachypneic,
done that, I'm gonna
hypotensive, and
get a
hypothermic
couple of
throughout the
lines and some
journey.
bloods. We're going to
Yes.
do
And you haven't given him
trauma
pre-hospital
because he's been
treatment.
quite
Haven't given him anything,
agitated.
haven't managed to get
I know
anything
he was
into
going
him.
to shake
Fantastic.
his head quite a
Thank you,
lot.
Sarah.
Came in, so
Bye-bye.
I'm
Will you
not
please
doing
book him
anything
in, and then we'll
fine.
crack on.
I'm
Will
not
do.
sure
Thank
that
you so
will
much.
be
You actually let me know what I'm doing.
Okay, so we're going to have a look at your chest here, Dave. Is it painful around here? Okay, that seems quite soft. So I'm happy with the airway because he's been quite agitated and he was thrashing around. when
Dave,
he
I'm
came
Jay,
in.
one of the other doctors.
Who?
I'm Jay, I'm one of the other doctors. You're in the hospital.
Where?
This is the emergency department at the Leicester Royal.
Went to train.
We're not getting on a train right now. We need to find out what injuries you've got from the fall.
Dave,
What for?
you had a fall at home this morning. I just need to have a feel of your tummy if that's okay, just to make sure that we don't think you've injured anything there. Quite painful. Dave, are you feeling as though you need to go to the toilet?
Yes.
Yes. Okay. Okay, so it's not that. I can feel the bladder.
So you're happy with this
So
airway?
in terms of how I've got so far with my primary survey,
Oxygen.
airway I'm happy with because he was thrashing around so much when he came in. I've not instituted any C-spine
Okay,
control
okay.
because I don't think he would tolerate
Okay,
that, and I don't
okay.
think that would be in his best interest. His respiratory rate is slightly raised. He's got quite a lot of bruising.
I know it's uncomfortable. Try and get those.
Keep it on the side, put it on high flow if he doesn't tolerate it.
Yeah, he's not tolerating that. We'll just put that to the side. So there's quite a lot of bruising and contusion to the
Yeah.
left side of the chest, so
Yeah.
there is some reduced air entry.
Okay, so
Can't
there's a
see-
B problem.
There's definitely
Yeah.
a V problem. I can't see
Okay.
any obvious flail
Okay,
segment,
okay.
but bearing in mind that could
Okay.
be there. The abdomen is soft. He's tender suprapubically, but I think I can feel a bladder, so he may be in retention.
Or he might have a pelvic injury as
Yeah,
well, given the blood
absolutely.
pressure.
So just moving down,
Yeah,
very uncomfortable.
Yeah, okay.
Just
fine.
this left leg looks slightly shorter,
Okay.
and that seems very sore. So definitely potentially a pelvic problem. So if we get a pelvic, think about pelvic binder, but it
Okay.
may just be a hip
Okay,
and
okay.
femur
And what have
seem
we
okay.
done so far?
So Jamie's got some IV access, and
Okay.
you sent off. Oh, getting some IV access, and we're going to send off the trauma bloods.
David,
I
just do a
will
little blood test from your hand.
get a bolus of warmed fluid.
Okay.
I was going to go with 500 mils of normal saline to
Liter.
start with. Okay,
Let's just see
Okay.
what he does.
we'll give him a bolus of
Yeah.
fluid.
And
Obviously, we're going to
some pain
need,
relief.
yeah,
Yeah.
Yeah.
And
definitely,
What else do
and
you
perhaps
want to
some anti-sickness.
okay.
Want to get some imaging.
What do you want?
So definitely need a chest x-ray and an x-ray of the pelvis, but bearing in mind that he may have fallen full flight of stairs, I mean, would we think about a CT in him?
Yeah, that's probably the best. Why don't we get a CT of the head, chest, abdomen and pelvis?
Okay.
And if it's cooperative, I'll get the neck as well. I mean, he's unlikely to have an unstable injury.
Yeah.
It's probably going to be something stable, but still worthwhile imaging because it's major trauma.
Yeah.
And if you're considering something going on here and something going on here, chances are there is something going on in the middle as well.
Okay.
So getting a CT will be a good option.
Okay. So
Okay.
I'll go and request that.
Let's do that.
Who are you?
Morphine for analgesia?
I'm Jay, one of the doctors.
Yes, that's
Have
great.
we got
I'll,
the?
get
Should
back
we?
to
We're going to assume we got the cot signs up, and we are going to stay here and not leave him.
With the daughter.
We are going to give her a ring. Have you got a telephone number for her?
Don't know.
Okay, well, I will try and track him down. Okay, shall we?
Where are
A
we?
painkiller. Just going to give you some painkillers, Dave, make you feel a bit better. Alright.
Oh!
That should help with your pain.
Okay. So you're entitled to give the actors a little round of applause just to take them to the rest of that. So hopefully in that second scenario you spotted some differences rather than me drip feed you. What did you see?
Just thinking outside the box instead of thinking sepsis.
Yeah.
sepsis.
So I think
Big
part of the
picture.
key difference was the approach. So before they start, well, at the same time they started the resuscitation, there was a discussion about the mechanism of the injury, the nature of the injury, the a priori risk of serious trauma. So rather than the slightly haphazard, random process that you saw in the first scenario, in this second scenario, there was a much more structured approach, treating the patient as if he had trauma, which he did. So they were using the ATLS algorithms, structured approach, and very carefully coordinated team working. So the senior doctor was briefing, taking a hand over, the junior doctors were getting on and sorting out the bits that needed doing. The outcome of that, as you will hopefully have observed, was a slightly calmer, more structured, more controlled resuscitation event, which didn't result in Dave coming off and falling off the leg. So, that's a flavour of what we're about today. Is Dave ready for us?
You might be trying to rejoin it.
So I'm just going to hand over to Dave, who's going to do the formal introduction to the rest of the conference. Okay. Oh, there you are.
Thank you. Good morning, ladies and gentlemen. I should say delegates. For the purpose of the Italian contingent here, I should say buongiorno, come sta? Where are they? Oh, see. Yes, I hope you found the role-playing informative and even though a little bit amusing. And I'd like to welcome you all here today on behalf of the first conference, the Geriatric Emergency Conference. And I have been here for 7 or 8 years and working in the Leicester area. And those that don't know Leicester, it's a city where King Richard III was later interned, and also there is a football team, I think, won the Premier League championships, and we have a world snooker champion as well, I believe. And just down the road, I think it's where DNA was first found or researched. So you're in quite a good area at the moment. I've been a patient advisor and latterly a patient partner for the last 9 years. I'm attached to specialist medicine and emergency and specialist medicine, CMG, within the Royal Infirmary, and have been doing that for 9 years as well. I'm also an older person's champion and also a dementia champion. And I would like to say that when an elderly patient is admitted to ED, their emotions are already being exacerbated by the injury or illness that they've suffered before coming in. And obviously a lot of their emotions are on overdrive, resulting in various feelings of behavioural actions, and they can be apprehensive, fearful, vulnerable, lonely, disorientated and confused. These feelings can also be increased if the patient has no support from family, friends or carer, which I think is most important. I see so many elderly people coming into resus, into majors on their own, and that's frightening in itself. So it's nice if they can have some form of support. It is vitally important that in the first instance, a person that meets them, either a clinician or another member of staff, is empathetic to them. A smile works wonders, because I always say that if you come into a strange area and you're already ill, and the first person you see smiles, it puts you into that mood yourself that you're going to have a good patient experience, and it can follow you all the way through your path in through the hospital. If a clinician comes up to you first instance and say his body language is not good and he doesn't smile, is abrupt, then your experience is going to be negative, not just in there, but you'll be looking for negativity all the way through your pathway through to the hospital. When excuse me about this. The thing is, you see, I have to refer to my notes, because when you get to a certain age, your photographic memory starts to fade quite considerably. So it's just that it's vital a member of staff interacting with a patient shows a degree of empathy, compassion, encouragement and reassurance. All of these virtues can also aid recovery, making a good patient experience. Finally, I would say that when we interact with many older people, we perceive the biological aging. That's what you see. You see an old person, normally anyway, unless it's David Attenborough, someone like that who's 90 and is still, acting like a 20-year-old. And in fact, talking to someone with a mental age, rarely, of say 40 or 50. If you see what I mean, you look at a person that's old, but when you're interacting with them, in a lot of cases, they are 40 or 50 mentally. And I think this is a thing that we have to look at quite considerably now. Not, well, there must be gaga, or there must be this or that. And as we know, some patients, unfortunately, suffer the ravages of dementia. But even then we should not treat them as though they were children. Well, thank you for listening, and I think that concludes my little talk to start with. Okay, thank you.